It's 6:30. Whenever we are ready, we can start. Should we start, Parna? Nilima?
Yes, I think we have already 62
Yeah,
participants.
62 people are
Yes,
there and
yes.
people will be joining in the next 5-10 minutes. So I think we can at least start with the introductory part.
Yes.
May I?
Yes,
Yes,
yes.
yes, yes.
Yeah. Uh, Good evening, everybody. Before we start today's meeting, I would like to pay my respects to Dr. Shrikant Babulgaonkar, a very senior anesthesiologist from Thane, who expired 2 weeks ago. Let us all pray for 30 seconds for his soul to attain moksha and then start the academic session. So good evening, everybody. It gives me great pleasure to invite you all today for this very exciting webinar on the indigenous intubating aids. So when we are studying as a resident, we are very happy souls because we have always have somebody senior to cover us. But as we step out into the world of private practice, we realize that we are all alone. And the thoughts that will I be able to intubate, will I be able to give this difficult spinal do cross our minds. But fortunately for us, we have some very interesting indigenous products that have been designed by our very own people. When you step out, you are new, you have no money, and you think, oh, I cannot afford this fiber optic bronchoscope. I cannot afford this expensive video laryngoscope. But we have some great people like Dr. Vivek Gupta, Dr. Mangal Dave, Dr. Hemant Dambale, who have devised certain devices which are cheap, which are easily affordable, and are very helpful to the new and all the private practitioners who are practicing single-handedly on a day-to-day basis every day. So I welcome all the dignitaries, all the speakers. I welcome Dr. Katkade sir, Dr. Anita Nete madam, President of SAMS, and my secretary, Dr. Parna, Dr. Nilima, Dr. Shamini, and all you lovely people for today's webinar. Without further ado, let us just start the academic session. And I invite our moderator, Dr. Shantaram Pavaskar, to take over the reins. Dr. Shantaram is a young anesthesiologist from Thane who has been practicing a lot of orthopedic and other cases. His primary interest being regional anesthesia and blocks. So over to you, Dr. Shantaram. Let us start with today's academic session.
Thank you so much, ma'am. Good evening, everyone, respected seniors and colleagues. So today's webinar is on aids for difficult airway. And our first topic is handling difficult intubation with TASCOP by Dr. Mangal Dave sir. So Mangal Dave sir is working as a chief consultant anesthesiologist at Gokul Super Speciality Hospital, Rajkot. He has more than 22 years of experience with majority of work in neuro, trauma, ortho and spine surgeries. He is famous for his affordable video laryngoscope, TASCOP, special interest in field of airway management and neuro anesthesia. Over to you, sir.
Thank you very much, Dr. Shantaram. Yeah, as Madam rightly said, day in and day out, we are intubating the patients. And many of the times we face difficult anticipated and unanticipated difficult intubations. So actually, we all have a need for some instrument which is handy, which is inexpensive. It should be easily available, easy to carry all everywhere. It should be ready to use very fast, and it should be effective in intubating the difficult cases. So, as Dr. Shantaram said, I am working in a neurotrauma. Majority my work is in neurotrauma, and I used to face a lot of difficult intubations. So, necessity being the mother of invention. I was in search of finding some device which can help all the our anesthesiologists, and I got the inspiration from the TAS, the Anesthetic Society group Facebook, that someone is intubating the patient with using of an endoscope fixed on a steel plate. From that, I got the this inspiration for making the TASCOP. Sir, next slide, please.
Yes, sir. Sir, I will play that video.
Yes, sir.
Video one, na, sir?
Yes, sir.
Good evening. Thank you to Indian Society of Anesthesiology, Thane branch, and its office bearers, and Society of Anesthetists of
Volume?
So we can't hear you. Can you make it louder?
Shantaram, we cannot hear the video.
It's okay. It's okay. I will.
Can
Please.
you see the video?
Yes. We can
Okay,
see
you
the
are not able to hear it.
It's
Maybe
okay.
play the
I
video
will-
and sir can talk.
If the volume is not there, I can speak. No
Sir,
issue.
please wait for 2 minutes.
Okay.
Okay.
No, we could hear you actually initially.
Yeah.
Should I try it once more?
Hello.
Hello.
Sir, screen visible? है?
Yes.
Yes, sir. Slow.
Shall I? It's okay if it is the introduction of task scope basically. So you can skip that and am I visible right now? Okay, screen is being shared.
Sir, आवाज आ रही है ना वीडियो की?
नहीं अभी नहीं.
नहीं.
Yeah, now we can see you.
Ganesh, can you Dr.
Yes,
Shantar, it's okay if the video is not getting played. I can demonstrate.
Yes, sir, we are able to see you.
Yeah. So it is basically about the task scope. Okay, on screen I can see that. Okay.
We
Can
can
we
hear you, sir.
Can we stop the video and screen sharing, please?
Okay.
Yeah. So it was about the task scope. It got inspired from the Anesthetic Society when someone was intubating with endoscope camera fixed on a steel plate. So basically our old design was like that only, bent steel plate and endoscope camera fixed over it. We did many intubations. We did very research work on that, and we tried to find out the best optimum curvature required for our Indian patients. And ultimately we came up with this sort of curvature and design. This is the adult task scope, and which has an hyperangulated blade with endoscope camera fixed into it. And this gives us the liberty to intubate all adult male and female patients with a single blade. And most anterior larynx we can intubate with this kind of task scope. What basically we do is the endoscope gets attached to a mobile phone, and the mobile phone becomes the screen for endoscope. The task scope has a channel for bougie through which we introduce the bougie. Introducing the bougie, and the tip of the bougie enters into larynx. Once it has entered the larynx, from the slot of bougie, we take the bougie out and railroad the endotracheal tube into trachea. So this way we do intubation with task scope. There is a new design for pediatric patients, a pediatric task scope. It has size 1, 2, and 3. 3 different sizes of blades, pediatric task scope blades, and 1 endoscope camera, which can be fixed into any of the tubes, any of the plates like this, and kids can be intubated. So this was about our new design. It is reusable. We can disinfect it. It is ETO compatible. We can disinfect it with a soap water solution. And then after once it is dried, we can clean it with that sterilium cotton or spirit soap. Same way as we disinfect our regular laryngoscopes. The cost of the Tascope is adult Tascope is 7,000 rupees to individual anesthetist. The institutional purchase will involve vendor and GST billing, so it will be more. But for individual anesthetist, the adult Tascope is 7,000 rupees, and it comes with one Talwarkar 4mm bougie. And anyone can contact directly to me for individual purchases of that. Shall we move on to the next slide of the video, please?
Yes, sir. Yes.
Mantavan, yes.
Are you able to see, sir?
Sir, the hyperlink one, next
Yes,
one.
yes. This one,
Yeah.
right?
Yeah, this is a sparse teeth patient, old age lady with very sparse teeth, and regular intubation with our conventional laryngoscopes. There are chances of breaking the teeth. The tooth will come in between. The mouth opening is this much only, and you can see the Tascope easily enters into that mouth opening, one finger. The visualization of epiglottis and larynx, and introduction of bougie into the larynx. I think all are able to appreciate the clarity of the vision with the Tascope.
Yes, sir.
This is how the tube is introduced into larynx. All these videos are available on my YouTube channel. Shantaram sir, we move on to the next video. The only
Yes,
one.
yes, sir. Yes, sir. Are you able to see, sir?
Yes, video 3 is there. Yeah. Yep.
Hello. Demonstration of use of Tascope. Female 28 years, posted for breast lump surgery, conventionally induced and relaxed. Patient's neck is in neutral position. You can see now the introduction of Tascope. With the two fingers, a little space is created in between the jaw, and Tascope is introduced, not moving or extending the neck. See the introduction of Tascope and midline approach. Walk over the tongue. Epiglottis is visualized going to the base of epiglottis and just lifting up. The larynx is seen. The vocal cords are seen. Once they are seen, the bougie is introduced to the channel of bougie into the larynx. And once the bougie has entered into larynx, the endotracheal tube is then railroaded over the bougie, and under vision, endotracheal intubation is done without any neck extension of the patient. Thank you.
Answering the questions in chat. Yes, it is very much useful for bariatric patients. And for pediatric Tascope, it comes with a pediatric bougie, 3mm pediatric bougie. iPhone and iPad 15 onwards, they claim to be external camera compatible, but suitable iOS app is still not very much available. I am trying to find out some app, but not yet found the suitable app for iPhone and iPad. Yes, Shantaram sir, we can play video 4.
Okay, sir.
This is the nasal intubation with the help of Tascope. She is a trauma patient with shattered mandible and maxilla. And you can see the blood in the oral cavity. She was not given relaxant because there was trauma and we were not sure about the structures, anatomy. So without relaxant, only propofol we tried with nasal intubation and we could achieve. Do you load the bougie before intubation? Yeah, it is one's own choice. Either we can load the whatever one feels good. Both loading the bougie previously and introducing the tascope, and once the tascope introduced, then inserting the bougie. Both can be used. It is our choice. Whatever we can do. Yeah. Thank you, sir. Thank you very much. All the four present videos are over. Yes.
Thank
Thank
you,
you,
sir.
Shankar. Yeah.
Can I say something?
Yes. Hello. Please,
Hello,
ma'am.
can I say something?
Please,
I
madam.
have, yeah. So I have purchased this Tascope from Sir just a few months back, and I'm finding it very useful. So initially, I had a few teething problems, and I would like to share them again with Sir. One thing is negotiating the bougie. I think we have to give it a proper curve, right? Before
Exactly.
giving it.
Exactly, ma'am. Yes, I agree. Yeah, we have to curve the bougie. This way we can keep it as a bangle. Keep it for 1 or 2 minutes. It will give the most proper curvature to the bougie. This way. Can everybody able to see this?
Yes, sir.
Yes, sir.
Yeah. So it gives, and then relax. The most this bougie, the material is very advantageous because it can be given shape and it retains its shape. So for Tascope, this Talwarkar bougie are very useful because of it is malleable and also it retains its shape. Yes.
Sir, and another thing, what I wanted to ask was, when we are connecting to the phone, should we keep the net on or off? Because I feel sometimes some advertisements start coming in the middle.
Internet is not required for Tascope to get visualized on phone. So it's okay if you switch it off, turn it off.
So thank you very much, sir.
Yeah, these are free app. They use advertises in between for.
Talwarkar is available with anesthetist.
Yeah, ma'am.
No, I was answering Parna's question.
Ji.
Even I also have your scope, sir.
Yes, sir.
Yes.
Yeah. One question is there any app is needed here? App is needed. App is needed to connect the Tascope to phone. Yeah. App is free from Google Play Store. With how much mouth opening we can enter? Yeah. This much. Sir, madam, this is the size, almost 1 finger, less than 1 finger mouth opening. Even if it is there, the Tascope can enter. 1.5 centimeter distance is required in between the teeth for the Tascope to enter into oral cavity.
Sir, I want to ask one question.
Ji, ma'am.
How different is this from King Vision? Is it because King Vision, what happens? The introduction into the mouth is very difficult because of that.
Yes, yes. King Vision is almost 2.5 centimeter channeled one, and
Yes.
unchanneled one is like 2 centimeter to enter. And because of a hyperangulation, it is very sometimes, and with the extension, this much of extension is there with the King Vision. So we have to either disconnect the blade from the camera or the monitor and then introduce. It sometimes hits on the over the chest while introducing. But with Tascope, I don't face such kind of problems. And what else what we can do is instead of introducing this way, if we can introduce this way,
Lateral,
so the
yes.
chest will not come in between, and we can negotiate. That also
Yes.
can. These are all tips and tricks, madam, that can be tried.
Unless you extend the neck, it is very difficult to introduce the King Vision.
Agree. Yes.
Extend it too much. Yes.
And with Tascope in neurotrauma, with all cervical collar patients, we can introduce and intubate without any difficulty and or neck movement. Yeah, I will share my mobile number on this. The price is 7,000 rupees for adult Tascope, and I will share my mobile number. Anyone can contact me for purchase. Yeah.
Can I talk something? Can I talk?
Yes, please.
Sir, congratulations and thanks for the wonderful presentation and congratulations for wonderful device.
Thank-
Now that this hyperangulation blade and your normal bed, because previously, excuse me for this, previously GlideScope had a hyperangulation blade and Karl Storz came with a normal blade, let's like a McGill's blade. Okay.
Yeah.
Now, what has happened? Karl Storz has captured a market over a GlideScope. I'm sorry, I'm not against, but people who are using GlideScope and people who use Karl Storz also, they found Karl Storz better because of the curvature of the blade.
Yeah.
Now,
Yeah.
for hyperangulation blade, if you have difficult intubation, it works beautifully well.
Agree.
But if you have a patient whom you attempt a video laryngoscope right in the first stage, it may be slightly difficult.
Okay,
So,
sir. Yeah. The thing is, you are very right, sir. We are trained with straighter blades. We are trained with even our tubes are straighter. Our
Yes.
tubes straighter. So we are very much comfortable with straighter blades, as you said. You are completely right. But and we even face difficulty if it is hyperangulation. But what happens with Tascope is we have a channel for bougie, so through which the bougie can be guided, and it can be guided and it can be introduced easily into the larynx. So that way, this is the advantage. I don't face any difficulty in any patients, sir. I have many videos you can see on the channel in which this disadvantage of curvature is overcome with Tascope with the channel for bougie.
Great. Thank you, sir. Thank you.
Thank you, sir.
Hello. Hello.
Yes, who's
Yeah.
speaking?
Hello. Myself, Dr. Nilima Chincholikar from Jabalpur.
Yes, madam.
मेरा एक क्वेश्चन है सर कि will it be helpful in emergency obstetric cases when the patient is more than 90 kg weight?
Yes,
When the
it is.
short,
Yeah.
thick neck and big breast.
Yeah. Yeah, as I said, madam, the chest is the breast is more. So instead of introducing the Tascope like this, we can introduce this way and then come. That will be helpful. Yeah, this is the trick.
Okay.
If we try to introduce like this, it will come in between. So I introduce from the sides, from the angle, and then come and do scopy. That will be helpful.
Okay. Okay. Thank you. Thank you. Thank you.
Can we move to the next speaker now, Dr. Shantaram?
Yes, ma'am.
Please introduce
Hemant
Dr.
Ambale,
Gupta.
sir, are you there?
Yes, he's there.
Oh, yes, I am there.
Okay, sir. So welcome, sir. So our second topic is
Thank you.
Dr. Dambales Vissel, torchbearer in difficult airway. Sir is highly experienced and dedicated medical professional with an MBBS and MD from MD in anesthesiologist from prestigious institution in Mumbai. He MBBS is from Grand Medical College and JJ Hospital Mumbai. MD anesthesiology is from SET GS Medical College and KM Hospital Mumbai. He was assistant professor in GMC Chhatrapati Sambhaji Nagar and professor in SMBT Medical College Nashik. He is a patent holder for HD's Vissel and patent file for HD's spinal needle. Over to you, sir.
Yeah. Am I audible and visible?
Yes, sir. Yes.
मी दिसतोय?
थोड़ा
Nice.
Hello?
blur, थोड़ा लैग होता है सर.
We can see the screen, sir, but we cannot see your face.
But am I on?
We can see and hear you, but
Hello?
your video, yes, now we can see you and
So
hear
it's
you
okay.
both.
We can. Okay. So, hello everyone. I am Dr. Dambal. I am professor in SMBT Medical College. I have been working in SMBT since last 12 years. We had a very much problem regarding the availability of fiber optic in SMBT, plus the cost. Am I audible?
Sir, you are audible, but video is
Yes,
not.
yes, Hemant. No, you are audible, but there is a
No,
light
it's okay.
in your face. But you are seen. You
Screen.
can face the
So
light.
I'll change. I'll change. देखा वो.
So should I share your
Now, is it?
PPT? I think there is a network problem. That's
No.
why it is showing network bandwidth is low.
Okay. Uh, Just a second. हेलो. आता ठीक है. हेलो.
हाँ सर आवाज तो है
हेलो.
You are
हाँ,
एक
audible
मिनट.
with video is yes your video.
Hemant, you can switch off your video so that whatever bandwidth is there, your audio will be better. If you have a less
Okay.
bandwidth, switch off your video.
Okay. Screen presentation दिसतंय माझं?
हो this there.
Yes. Okay. So I have designed Dr. Dambale's whistle for awake nasal intubation. So it's a very interesting story. So for me, it was only my fortune or luck, I can say. So actually, my daughter wanted me to blow a whistle. She bought from a local fun fair from here, and I denied the idea that I won't whistle this, and I'm watching a cricket match or something like that. But she managed and inserted it very forcibly in my mouth. There was some particle on that. It irritated my pharynx, and I coughed out, and the whistling sound came out. So after a while, the tube lights started blinking, and I said, "Why not do this something like this when we do awake blind nasal intubation? Because patient actually coughs when the tube is in place." So I took the whistle and to the OT. First, I connector with pep sticking first time and with Dynaplus second time. Both of time the tube was in, the patient coughed, but the whistle was not making any sound. So we referred to. So it was very clear that there should not be any air leaks. So third time we used M-seal and we got an airtight chamber. So third time the whistle made a huge noise also. Then we searched on internet. There were some air amplifier, but none had the oxygen port with them. Decided to add a oxygen port, but oxygen port had the risk of leak and whistling itself. So again, I referred to physics books. So it said ki minimum airspeed for whistle blowing required is 50 ml per second. So we calculated the flow per second and we opted for 2 liter per minute, which gives you approximately a flow of 35 ml per second. So we landed safe this time also. So this is our baby whistle, which we did with M-seal, and we did at least 15 to 20 awake blindness and intubation with this technique, with this whistle. So after some days, when some seniors told me that this is not known to many people, this is very novice technique. patent it and you should go for prototype. So prototypes were not readily available to us. So I went to, we have MIDC over here in Satpur MIDC. I went to a local toy manufacturer who gave me idea ki sir, you will need a human grade plastic, 3D designs, and there is liquid resin techniques, and there is injection mold for the final product. But I just asked him, "Ki, boss, you just give me a 3D printed device, I will give you the drawing." So he gave me that prototype. And regarding patent, we were very no started a search for a patent lawyer who in a patent attorney. So it took us 3 months patent attorney, and she was very knowledgeable and cooperative, and she knew beforehand that I am very new. Uh, Cooperated with me, and the patent was filed within 15 days. So last year it was published, and it is now safe. Nobody can copy, and it is now available to public online. You can access it by putting the patent number. So let us. I mentioned physics books twice, but what is the physics behind Dr. Dambale's whistle? So as the air from the trachea enters at one end and reaches the other end, the closed or air molecules will pile up on each other, creating a high pressure zone. So just like a pressure cooker, when the pressure inside the cooker exceeds the atmospheric pressure, the air will escape through the narrow opening through that pressure cooker whistle and here our whistle. So it will make a continuously air make noise, and we have added the small balloon, small metal ball is added to make add a trill to the sound. So this is the physics behind our Dr. Dambale's whistle. Now advantages, the time required is very much less than 5 minutes. It is highly cost effective. You just have to spend so amount. Airway blocks will suffice most of the time. Learning curve, limit, even a first year, second year resident is doing hassle free. Inline oxygen supply to the patient is available, so the risk of desaturation is decreased very much on the lower side. Even a trainee doctor can do. ETCO2 graph appearance takes 6 seconds, but it gives you the real time confirmation of successful nasal contamination or damage to the whistle, as the whistle is nowhere touching the body. It has zero maintenance except if it gets to sterilize it and you wash it with water also. And it can be made available in the remotest possible setup. You can carry the whistle in actually in your pocket and go to the this thing. Now it has some proven advantages also. Some ENT surgeon told me it is used for the false passes are more physician appreciating ki boss, this is a very good device, especially in emergency intubation when you have obese patient. The whistling noise confirms auscultation sometimes is confusing in these patients. Even air mist not seen properly. And recently, one of the veterinary surgeon also approached me ki this whistle can be used in. Hello, hello, am I audible?
Yes, sir, you are audible.
You're audible.
One of the recently, I don't know whether shall I say this or not, but recently a veterinary surgeon approached me. We intubate our dogs in spontaneous breathing. It's a difficult intubation. Your whistle can be tried in dogs also. I said, okay, you can take a whistle from me. So these are all things in pipeline. So I have made a short video. The procedure we follow in SMBT. So till date, we have intubated almost 100 to 200 patients for maxillofacial surgery, CA mandible, CA buccal mucosa, and saved at least 5 to 10 lakhs rupees of tribal patients here. The video have sound at the end. So this is administration of lignocaine jelly. Nasopharyngeal airway don't actually dilate, but it tells you the direction which you should go to. Always hold the needle at the base, so the while coughing, the patient needle don't get dislodged. After calculating the total toxic dose, I prefer giving 2 ml of again through tracheal route. So the upper part of the vocal cord is exercised, so patient don't fight. This is ETCO2 validation. It takes 6 seconds, but whistling sound comes immediately after intubation. So we are on the process to publish the original article about this also. The beautiful air mist is seen here. Till date, we have sold almost, distributed almost 200 to 250 whistles. These are the responses all over India I got. This is from Calcutta. This is Tarun Waghela sir from Navsari, Gujarat.
મોડું ખોલો. શું નામ? નામ શું?
This patient had a Lee-Ford's fracture 3 grade 3. This is tracheostomy, revision tracheostomy patient. This is from Dr. Manisha Katikar from Solapur. This is again me. करो, सांस लो, हो गया, ठीक है? This is from a local member, Dr. Ashish Naik.
हे श्वास चल. श्वास घे जोरात. आरामशीर आपण नॉर्मल श्वास घेतो तसा श्वास घे.
You can actually come to know the amount of expired tracheostomy and intubation. So much for your patient learning and listening.
Excellent information, sir.
Yeah. For the question, Manisha madam has asked, do you give any sedation? We generally differ from giving any sedation, madam. But if at all the patient is anxious, you can give sedation, but proper counseling and all that will elevate 90% of our problem. I would like to show a demo. So this is Dr. Dambale's whistle. This is oxygen port. This is endotracheal tube. And you have to attach it like this. To start with, we prefer 7.5 number tube in males and 6.5 tube in females because it is relatively I say slim tubes. Then after intubation, we exchange with bougie a bigger tube. It becomes painless and easier for anesthetists because we have given a proper GA. So airway pressures are maintained within normal limits. But to start with, always prefer 6.5 for females and 7.5 for males only. Yes, you can do oral intubation if you are not if you are going for awake oral intubation, madam.
Very good innovation, sir.
Thank you so
Um,
much.
I remember when we were residents, what we used to do is we used to put a tiny wisp of cotton to the blue connector. And when you used to do nasal intubation, with every breath, when you are near the larynx, it used to move up and down. And that used to be one of the guiding factors that we are in the right direction.
Recently, for changing the direction, we have incorporated a new idea. We actually tie a thread here to the Murphy's eye, and it is accessible to you in to nose. So when you pull your thread, na, so you can actually manipulate the tip. So it's
It
also a
acts
good
like
thing.
like a flexible stillet. It will
Yeah,
act.
yeah. So it is very useful in flexometallic tubes also.
Yeah.
So you can actually it behaves like a stillet in this part only. So that is also one idea.
Hemant, one end is tied at the Murphy's eye and other end of the thread comes out from where?
Outside the tube.
Oxygen port.
Outside, it is outside the tube only, madam.
Outside the tube.
Outside.
पण
Okay,
माझ्या हातात
okay.
असतो इकडे नाकाच्या इकडे.
अच्छा, हाँ. Okay.
So you can manipulate. असं आहे.
Even I think previously we used to attach the Bain circuit or the Magel circuit to the tube, and we used to see the bag movements going when you near the entrance of the larynx. And we could even give some inhalational agents also if the
Yes,
patient was coughing or
sevoflurane.
something. So
Yes.
that was helpful in intubation. But very nice. I remembered one case I had done where a whistle had got stuck in the child's throat. And we knew it was in the throat, that is in the larynx, because every time he breathed, the whistling sound used to come.
Yeah.
This was 25 years ago, पण मला तेव्हा चमकलं नाही. Otherwise, it would have been Dr. Manisha Ghosh's whistle.
Parna madam has asked, is it necessary to change the tube? Actually, madam, तुम्हाला you will get the idea by looking at the peak airway pressures. If that 7.5 number tube is serving the purpose, then you don't need to change the tube.
And for changing the tube, you railroad the bougie?
Yeah, we'll railroad the BG. Yes, madam.
Very good, Hemant.
Thank you so much.
I think both the innovations that we have seen today are really excellent, and they are very affordable to the practicing new anesthesiologists. Their mobile phones are more expensive than the innovations that is going to help them in intubation.
Even sometimes patient has a more costlier phone than us.
Exactly. Wonderful.
Yes.
Can I talk if you?
Yes, please, sir.
See, good old days we used to intubate the patients with open ether. I'm sorry for this. I started my career in 79-80 in anesthesia, now the 76. So when we used to give open ether, we used to make the patients to have hypercarbia.
Okay.
And we used to have blind nasal intubation. The basic rule was every breath sound is to be heard, seen or felt. Every breath sound was to be heard, seen or felt. And the patients used to hyperventilate when you used to give put a hand on the Schimmelbusch mask, and patient used to hyperventilate, and that used to direct the patient's breathing and endotracheal tube. Lots of blind nasal intubation. In good old days, we didn't have any flexible fiber optic bronchoscope or anything. But the blind nasal intubation was an art.
Yes.
So this your whistle reminded me of this art, and we used to the anesthetist used to put an ear on the patient other end of the tube, and they used to manipulate. Plus red rubber tubes, there were special nasal red rubber tubes.
Yes.
Angle. So, but congratulations for your excellent innovation. Thank you very much, and we are glad that you got it patented, and very nice.
Thank you so much.
Thank you. Thanks to.
Yes.
Hello.
Yes, madam.
Yes. I had done many blind nasal intubation. Just now, sir told. Just I used to listen the voice, and I used to attach the Bain circuit to the tube, and maximum back movements will guide me for blind nasal intubation.
Yes, madam.
Yes, so that can be done very well. And when maximum blind back movements are there, you have to just you are in the vicinity of the larynx, and you have to just slip the tube in the larynx, and that is definitely helpful. I had done near about 50 cases of TM joint ankylosis without fiber optic bronchoscope like this. But this whistle idea is really good.
Thank you so much, madam. Price of whistle, madam, for Maharashtra, it is 2000, including delivery and GST. Out of Maharashtra, the delivery charges gets double. So I am charging only 2500 for out of Maharashtra peoples.
Can we move to the next speaker?
Oh, sorry.
Sir, if you have to say something, please say, sir.
Interesting,
Okay,
you got
sir.
it patented. What is the procedure to get everything patented? Just to
Sir,
yeah.
so, now that I know three patent lawyers. One of them is in Pune. You just have to contact him, and you have to tell your idea in the language he understands, he or she understands. You have to give them a rough diagram. So,
Oh, yeah.
and then they will, what we say, articulate all your ideas, and then they proceed accordingly.
Oh, very
And
interesting.
they go for a search report. It takes them 3 months. They go for a search report, then they find out whether something like this is existing or not. Then only if he is, of course, if he is genuine only, then only this is possible. Then he will tell you, ki, sir, this is a newer device. We can file the patent. Then they take our consent, they take our nominees, and some fee money is a bit on. It is a bit costly, but definitely fame is more important in our case. So
Good, great. Congratulations.
Thank you so much.
Thank
Thank you.
you.
Thank you so much.
Thank you, sir.
Thank you, Shantaram. And thank you so much, all the ISA Thane people, organizers, to invite me. I was actually going to say this, but I was very nervous initially. So thank you once again. Thank you so much. And Shantaram is my junior from KM.
Yes, sir. KM. Yes. So we'll move on to next topic. Vivek, sir.
Yes, sir.
Okay, sir. So the next topic is innovated buji for difficult intubation by Dr. Vivek Gupta. Vivek sir is in anesthesia practice since 1980. He's a senior consultant anesthetist at Saroj Hospital and in Delhi for last 30 years. He has innovated difficult intubation buji, started Facebook group, the anesthetist, now Global Anesthesia Society, now having 36,000 members worldwide. Over to you, sir.
Okay, am I audible, visible, and this slide is visible?
Yes, sir.
This slide is visible. Okay. The previous two speakers, their innovations was really very good for this intubation difficult. But my innovation is also very good. You will find it. I am presenting a indigenous buji made by me. Okay.
Sir, can you do full screen?
How to do full screen? वो कैसे करते हैं?
Sir, at the bottom you will see a screen picture. You just have to click on that.
Yeah.
हो गया?
सर एकदम डाउन में वो जो प्लस माइनस है ना, माइनस के बाजू वाला प्लेस करो, माइनस के बाजू वाला, नहीं माइनस के लेफ्ट साइड वाला, हाँ वही नहीं सर, वो नहीं जो प्लस माइनस है ना सर, हाँ ये देखो माइनस है ना, माइनस के बाजू में एक ये नहीं नीचे रखो सर,
माइनस के बाजू का आइकॉन है जैसे ग्लास।
हाँ वही बराबर,
गॉबलेट जैसा दिखता है, ग्लास जैसा।
ये हो गया?
नहीं
अभी वो थोड़ा कम करो। हाँ हो गया यस।
So this difficult intubation is every anesthetist nightmare, and they struggle to see how to do a difficult intubation. The armamentarium available for difficult intubation is fiber optic laryngoscopies, buji, McCoy laryngoscope, video laryngoscope, and fast track intubation. Video laryngoscope is the gold standard, but it is very costly and it requires real practice to do a fiber optic intubation. And we do, and most of the places this fiber optic intubation, fiber optic bronchoscope is not available. Right. So I have designed a bougie please, sorry. The bougie of different types, Ashman and Portes, they are commercially available. But the problem with them is they are very costly. They lose their stiffness very fast and they are difficult to carry, cannot be folded. And I have designed a bougie with a different material that is very affordable, can be folded. Angle of the bougie is soft and flexible, and so it doesn't damage trachea and can be carried into pocket and last lifelong. Because the bougie I am using for myself is almost 10 years old. This is my bougie. This is some Portex new bougie, and this is Portex old bougie. You can see how flexible they have become, and mine is still stiff. Now, this is the video of using my bougie. This is another video which I made some few days back. You can see the glottis is not very easily approachable, not visible. How the angled bougie is going inside smoothly. Another major difference is, whereas the angle of the available bougie is hard. Some anesthetists, they recently pointed out to me also that angle of the bougie is hard and it is very difficult to negotiate it into trachea. And some company has recently introduced this flexible angle bougie. You can see the difference between and this commercial bougie. This is very hard. So bougie is not only used for difficult intubation, it is can be used for this like buck teeth also, so that they don't get damaged. By just doing a very little laryngoscopy and introducing the bougie, you don't put fulcrum on these teeth, and so that the intubation can be easily done. Now, I have also introduced the straight bougie for difficult nasal intubation, which people don't do it. Now, this is the angled bougie in oral. This is for oral intubation. You see, this is the angle, and here it comes, and then it goes. So we need an angle at this point so that for intubation, right? But if you introduce this angled bougie through the nose like this is going, it gets tangled at in the tongue so that it doesn't go straight into the trachea. So it needs a straight bougie for nasal intubation. Now this is the straight bougie. You can see it is going there and then it is going directly into the trachea. It is not going up like an angled bougie. Now this is the nasal intubation. Now, because it is difficult intubation, so we'll need this McGill's forces to introduce bougie into the glottis. So these are some of the testimonials from my users. Frankly speaking, even I have used this bougie for 2-3 times and found better than the contemporary bougies. I used this bougie in the patient who had 2.5 finger mouth, receding mandible and had anterior larynx. And I used Dr. Vivek Gupta bougie to intubate this patient. This patient made intubation much easier. These are some of the testimonials from my uses. Now my other innovations is this Riles tube introducer. This patient was referred to us from the ICU because they could not put Riles tube into the patient. This stellate I have especially made so that the Riles tube becomes stiff and it doesn't get coiled into the mouth and goes directly into the stomach. This is this difficulty I was facing, that the tube was getting kinked in this cleft palate patients. So I introduced a wire over the tube, this wire cover over the tube, so that it doesn't get pressed and kinked by this laryngoscope type. Last but not the least, I created the group, the Anesthetists Now Global Anesthesia Society, which has now more than 36,000 members from all over the world. Any questions, they are welcome. Hello?
Yes, sir. There is a question in this chat box, sir.
Chat box, where is chat box?
What is the material? If it does not have an angle, how will it help difficult intubation? Parna madam is asking.
Which angle?
Yes, Manisha, it is armored like.
Yes, sir. Dr. Sir, Vivek Gupta, sir.
There are two types of bougies, angled bougie and straight bougie. Straight bougie is for nasal intubation, and definitely angled bougie is for oral intubation. I'll show you if you can see. Like this is the angle. Can you see?
So my question was when you introduce the nasal bougie, which doesn't have an angle, it's a straight bougie. So then how is it going to go into the glottis? Because it doesn't have an angle. So
You don't need angle when you do a nasal intubation. That's I showed you on the plates that for nasal intubation you don't need an angle. You need angle when you do only oral intubation.
हाँ तो आपने वो मैगिल्स फॉसेप्स का दिखाया था ना, so मैगिल्स is used to direct the bougie into the glottis
Yes.
while you're doing it nasally.
Yeah, because that was a difficult intubation. That's why I had to use McGill's.
Okay.
But with angle, it is more difficult. For you have to have this straight bougie for nasal intubation.
Okay. And the material of the oral and the nasal bougie both are same or different?
Same.
Same. And
Yeah.
what's the material, sir?
Material is got it made from this medical manufacturers, the same as the rice tube material. Plus, there's reinforcement wire inside, so that the bougie
doesn't lose its shape.
kinked. No, it doesn't get kinked, and you can use it for almost any time, lifelong. They last.
Okay. And the Riles tube introducer that you showed, so that is like Freca tube that we use. Freca tube mein, Freca Riles tube has that introducer, something like this only.
Yeah, maybe I haven't seen Freca tube, maybe like this only, but this my introducer is reusable. I think Freca tube is not reusable.
Yeah, that we don't reuse. Okay. Okay. Thank you, sir.
Any question? Any other question?
Yes, sir. For that South Pole tube, the thing that you had used, is it a part of a armored tube that has been cut and put, or is it something different?
I have made this cover type structure so that I put it on the tube. So when they put this laryngoscope type thing, so that it doesn't get kinked by the these teeth.
By the teeth or by the blade of the
and the teeth and the blade, they don't compress the tube, don't kink the tube at the angle. This you can see here. This point, the tube gets kinked and compressed. So now with this armored wire, it doesn't get kinked.
So is this made in various sizes, or is it one size for all?
Actually, it is usually for pediatric cases. So 1 or 2 sizes, they are enough.
Thank you, sir.
Thank you, sir.
Okay.
So generally for nasal intubation, we use a North Pole tube. So this nasal bougie can be put through that, because if you put something in the nasal North Pole tube, because of its curve, it's very difficult to take it out.
You see, here we have put this north nasal tube only. Just see.
Okay.
Just see. Yeah, see, this is north nasal tube.
Okay.
So this bougie I have made around 80 centimeters so that it can be used in this preformed tubes also. The commercial bougies, they are around 60 centimeters. My oral bougie is 70 centimeter. My nasal bougie is 80 centimeter. And this straight bougie can also be used as a tube exchanger.
So it has an oxygen port also, or it doesn't have?
No. Oxygen port I tried to make, but it was very difficult. So I left the idea.
Okay.
But it is going in my mind how to make a oxygen port bougie so that we can oxygenate the patient. But it is another idea is to make to put light at the end of the bougie, LED light. But it looking very difficult.
Then
हो
video
जाएगा,
stillet,
कभी ना कभी तो हो ही जाएगा.
yeah. Video stillet is also available now. So it's like a stillet
Yes,
on which you can see,
that is available.
visualize. Yeah. What is the cost of this bougie, sir?
It is around 2.5 plus courier charges.
Thank
And
you, sir.
I have sold almost more than 1,000 pieces. Malab, I am getting repeat orders from so many doctors, hospitals, nursing homes.
That is a very useful device, sir. In fact, I think the first thing that I bought along with the other laryngoscope and all was a bougie, and it has saved us in many critical situations.
My bougie or some other bougie?
No, before this, some other bougie which I brought years ago. So your bougie will be the next purchase, sir, this month.
Yeah, once purchase will last you for lifelong.
Yeah. Thank you, sir.
For this type of teeth, I do this. क्या कहते हैं उसको? molar laryngoscopy and just introduce bougie so that we don't have to put pressure on these teeth.
Any
Thank
more
you, sir.
questions of the audience?
Manisha,
you, sir.
sir's bougie I have. What happens is it doesn't listen to us. It is very soft. I mean flexometallic jaisa. So if you use the vacuum suck tip, keep it at the tip of the glottis and guide the bougie through it, so it goes easily.
Okay.
Yeah.
Shantaram?
Okay, thank you so much
Yes, ma'am.
for giving me chance to speak on my bougie.
Thank you, sir. Welcome.
I think it was okay.
Very good,
Yes,
sir.
sir. Yes, very good, sir.
Okay, thank you so much.
So, should we move on next topic, ma'am?
Yes, please.
Yes, the next topic is blockbuster LMA revolution in intubating LMA by Dr. Kala ma'am. So Kala ma'am is a freelancer consultant anesthesiologist in Dombivli, Kalyan area. Madam has 10 national and international publication, Nisora poster presentation, pocket book on regional anesthesia available in Amazon. Madam has a very big list of achievements and awards like COPS Private Practitioner National Awards, ISACON 2016, Hall of Fame JRC 2017, Ganga Hospital, Coimbatore. Then Bhisha Gavarya Award, Brahman Sabha, Dombivli 2020. Faculty at various national and international conferences, conducts hands-on workshop on regional and difficult airway, YouTube teaching channel and special Facebook airway page. Special interest in regional anesthesia, difficult airway, and safe anesthesia practices at nursing home. 2024 IMA Dombivli Best Doctor of the Year Award. Over to you, ma'am.
Yeah, I cannot.
People presentation.
Can you see my screen?
Ma'am, you have to share it.
Yeah, but no. Just a sec.
Has
What
Dr.
is
Gupta
happening?
stopped sharing his screen?
I don't. Yeah.
No, not yet.
No, ma'am.
Gupta sir,
Yes, yes, now.
Yes.
Yeah, Gupta sir had not stopped.
Yeah.
Okay. So before me, everybody were talking about their own innovations. This is not discovered by me or something, but it is a very important equipment in the armamentarium of a freelancer anesthesiologist for difficult airway. And thank you, ISC Thani, for this invite. And I take this opportunity to thank all my mentors, teachers, surgeons, and my patients for giving me so much affection, guidance, and placed faith on me. No disclosures. The company is not supporting me to promote their product. I'll start with a case where I used it in dire emergency, the Blockbuster for intubation. Okay, a 56-year-old lady coming from Dubai, she came for total lap hysterectomy, mild hypertensive, controlled, and the BMI was 26. She was not very, the truncal, little bit obesity of post-menopausal. Neck movements was good. Mouth opening was very good. There was slight receding chin. This picture, what you see is post surgery, post-op I have taken. So it's more receding, but when she came in, it was not seen so much, but I could see some double chin and no associated comorbidities. And so the simple plan of action was around planned GA, good operation theater. I had all the resuscitative equipments ready, difficult airway card. I'm very fond of SGDs. So I have an array of supraglottic airway devices and monitors attached, workstation ready, all the routine things what we give. I do not mask ventilate that, but I use high flow nasal oxygen as pre-oxygen, and sedation, your regular Fortwin, midazolam, induced with propofol, and I give low dose scolin. And intubation, simply I could not. Conventional laryngoscopy, I could see only tip of epiglottis. I tried adjusting the head ring, the pillows, but still I could not improve my Cormack-Lihan. And external manipulation, I tried Buji. I did not have Vivek Gupta sir's Buji there, but the regular Buji refused to walk in. But so I just put in an LMA Supreme because patient had started breathing little movements, so ventilated with 100% oxygen, and the end tidal CO2, the ventilation, the chest rise, everything was good. So I upped the relaxin. I'm used to doing laparoscopic cases under LMA. So but then this case where I could not intubate, I did not continue, though I gave relaxant, inhalational, and then settled the patient, relaxed the patient well, and tried with VLS. I have a King Vision and a Torin video laryngoscope, but still the endotracheal tube did not go, and the Buji also refused to go through the channel. That means it was highly, though I could get a POGO score of around 80, but it was highly angulated anterior larynx. So I started thinking whether I can, there was fiber optic ready, but then you have to ready the thing. So I took in a SGD where I could pass the fiber optic through the supraglottic airway device. So I chose a Blockbuster LMA because I regularly use it for routine cases, but not for intubation. And while readying FOB, I just tried the flexometallic endotracheal soft tip thing which comes along with the Blockbuster, and it just slided in, and then I did a dual check confirmation with ETCO2, auscultation, and the graphs of the workstation. The ventilating graph was good, and confirmed the placement of the tube in the trachea, and thanked God for that. But nowhere my parameters were deranged. It was no tachycardia or no hypoxic and absolutely no trauma. Now, coming to Blockbuster, this LMA was invented by Professor Ming Tian in in China in 2012. It is known to improve the quality and safety, improved ventilation and wider intubation route. Second generation LMA because it has a drainage port and allows, because of the silicone cuff, long-term breathing, gives a solid seal because it has a posterior cuff also, and a higher success rate for blind tracheal intubation. It is marketed in India by Torin. Now, this is what we get along with the, you get a separate package of your tube and pusher, and along with the connectors, and you also have a two lubricant soak gauze pieces. The LME per se comes in a separate package. You can ETO and reuse the LME, but the tube you can buy separately. Okay. Now, what are the features of the blockbuster intubating LME? First of all, it has a silicone material. It has flexibility and biocompatibility. It has a huge, wide ventilating opening. Can you see the LME? I'm showing that along with it. Hello?
Yes, ma'am. Yes, ma'am.
Yeah. So it is a second generation with a huge, wide drainage port. Okay. And it has a dual cuff, just like your LME ProSeal. It has your regular second generation cuff and a posterior cuff also. So therefore, it gives a very good oropharyngeal seal pressures. And it has a short elliptical airway tube with fixed curvatures like Supreme. Okay. But what is this thing is like after your aura gain, almost all, see, you had your ProSeal, then the Supreme came, and then the Aura Gain came in. And since Aura Gain, the people have started using fiber optic through SGD for intubation, and that is why after that Aura Gain, most of them have your endotracheal tube size written, with the LME. So that is now, it is fiber optic compatible, and you can intubate through all the LMEs after Aura Gain. Okay. So, and hence they come with a short elliptical airway tube. This is shorter for your endotracheal intubation. And the angle between the airway tube and the cuff is 90 degrees. It is designed for easy insertion, okay, and easy exchange of endotracheal tube. It has a specific guide inside. I don't know whether you can see, there is a specific guide here, which does, though because it has a wider opening, your endotracheal tube might not go exactly in the direction meant. So you can cause a trauma or a failed attempt. So this has an exchange guide which allows the endotracheal tube to go in the specific direction. Okay, it has an inbuilt mouth bite and a 4-way connector fixation. Okay, the same thing here. This is your guidance device which is inside, that is very important here. Okay, coming to the features of the endotracheal tube. So this is a special patented ET. It has a soft Parker tip. You can see this as a flexible Parker tip here. Okay, and the tip is ending exactly in the middle. You will be passing it facing the tip posterior. So the opening is anterior. Okay, it is a flexometallic tube, and the tube is guided when it comes out of the, I don't have jelly at home. When it comes out of this thing, it is coming out at an angle of 30 degrees here. Okay, this angle is 30 degrees towards the glottis. So it is in alignment with the ventilation port of the LME itself. So easier chances of success for intubation. So this is a picture of the endotracheal tube that comes up along with the blockbuster. This is a major role for the higher success rate. It has a parrot-like beak. Okay, and there is a central lining, radio opaque line, which ends at the tip. Okay, so this parrot beak is facing posteriorly and the opening anteriorly when you're introducing, and this is the pusher that comes along with it. Now, there are various sizes of blockbuster LMAs from the pediatric 1, 1.5, 2, 2.5, 3, 4, and 5. And unlike the other LMAs where you're using 3 for females and 4 for adult male, it is like 4 and 5. 4 comes for females and 5 for males. It will be better. And this is a chart wherein it shows how much volume of air is needed to inflate the cuff. But though it is better to do the cuff pressure monitors, and the ET, which goes through the blockbuster LMA, but it is written at the mouth bite. You can see what size of ET will pass through the respective LMA and what bronchoscope can be passed, that also. Okay, and the gastric tube accordingly you can pass. Now this is a video after I got that I felt it whether it is a tukka which I could get for an unanticipated difficult airway. This is after induction we get lost whether either we need a video laryngoscope, where video laryngoscope also failed, then you need a fiber optic. And meanwhile, whether I tried for intubating blind through a SGD. So I tried repeatedly to see whether it is, I get this success every time. And believe me, after that, at least 10 times I have tried, and every time it just slides in. So almost 99% success rate. So I just made this video at the so this is a sterile tray wherein open the new pack of ET, the gauze piece with the lubricant that comes along with the pack. This is a new pack which I opened for this webinar. After induction, you can see that the curvature is just walking along with the mouth opening and along the palate. Now we have reached the posterior pharynx that gives you resistance. 20 ml of air is injected in the cuff. The cuff is inflated. You can see it coming out. That is good placement. And the placement ventilation is checked with the EtCO2 and the ventilatory graph. Okay. And then I gave relaxants. Inhalationals deepens the plane, and meanwhile, very good lubrication is needed all along the endotracheal tube. See, that is the curved part. That is a Parker tip, flexi tip endotracheal tube that comes along with the blockbuster LMA. Now keep it posteriorly so that it glides along the airway tube of the blockbuster. At the exactly when it reaches the exchange guide, you will get some resistance. So push it more inside around 26 mark and then connect it while keeping it in the LMA, and dual confirmation with your auscultation, your ventilatory graphs, and your EtCO2. And note the marking of the endotracheal tube. Now you can deflate the cuff and keep it in place, or see, inflated the endotracheal tube cuff. At this point, you can either keep the LMA in place, deflating the cuff, or remove the LMA using this pusher. You keep the endotracheal tube in place, slowly pushing it inside while pulling out your blockbuster LMA. Okay. So as soon as you can hold the cuff, endotracheal tube and bring out the entire ensemble. It has a wide ventilating port which allows the inflated cuff to come out nicely. But still, I'll be checking the cuff of the endotracheal tube once again to see whether it is not damaged. See the markings in the ET tube, the ETCO2 and the ventilatory graph, and auscultate once again for bilateral equal air entry. Okay. This video is available on the YouTube also. Do not forget to check the inflated cuff again. No? Sometimes the cuff gets damaged. So now comparing the Blockbuster with other LMEs, this is a range of LMEs which I have. So you can see that endotracheal tube will not be going through your Proseal and your Supreme. From the Oragain onwards, all of them allow the endotracheal tube. So the comparison mainly is because it is introduced into the market as an intubating LMA versus the prior intubating LMA, that is a fast track. So we will start comparing between the other LMAs which can help you in intubating through the SGD. So what all the comparison criteria is, first of all, ease of insertion of the LMA, whatever maneuver is needed or not. The time of insertion, how much it takes to pass the LMA, the bulkier ones, sometimes they itself cause trauma. Adequate ventilation, the sealing, oropharyngeal leak pressures, how it is helping in no pericuff leaks. Okay, then Brimacombe fiber optic gradation. If you grade the to visualize the vocal cord, whether it is in line with the ventilating airway tube, and ease of insertion of endotracheal tube through it, whether any rotation is needed or not, the time of insertion of the endotracheal tube, the first attempt success rate or the second attempt success rate, the trauma accompanying it, whether patient has sore throat post-op, there is bleeding, or whether blood is on the device when removing the SGD, and overall hemodynamic stability, whether tachycardia, bradycardia, or hypertension or not. Okay, so comparing the Blockbuster intubating LMA with the fast track intubating LMA, both were compared as an intubating conduit, blind tracheal intubation. And in these two studies, and the first attempt intubation rate was found to be 96% almost with the Blockbuster as compared to 86% in fast track. The second attempt was better with the fast track because of you have this fast track, you can use the it has a metallic handle, which helps in the adjustment of the fast track intubating LMA, and overall success rate both gives better. But this is the angle of the tube coming out of the ventilating port. So the tube is almost in line with your ventilation port in the Blockbuster, that is around 27 to 30 degrees, whereas with your fast track, it is around 40 to 45 degrees. So what we do is you push down the metallic handle of the fast track, so that is called the Chandy's maneuver, so that this tube is in line, so this goes up and it becomes in line once it comes out of the, so that is why the second attempt success is better with fast track. Okay, and this intubating angle, I mean the cuff and the airway tube angle here is more obtuse, so hence the ease of insertion is better with Blockbuster as compared to, this is an 82, no, it is an acute angle here, less than right angle. So this you need to be, you have to change the direction. It doesn't go in one smooth this thing. So more comparison, that is ease of insertion depends on this angle, you know, more obtuse, the ease of insertion is better. And the direction, again, as I mentioned, this directs the ET tube towards the laryngeal inlet with an angle of around 30 degrees at the blockbuster. And this in fast track, the angle is around 40 degrees. And hence you need to do little maneuver by pushing the handle, okay, the metallic guiding handle. There is no epiglottis bar, elevating bar with the blockbuster, whereas you have an epiglottic elevating bar at which pushes the epiglottis out of the way to and provides an unobstructed passage for the insertion of endotracheal tube. But the blockbuster again wins because it has a second generation. It is a second generation with a gastric access for gastric decompression, and the fast track does not. It's a first generation with no gastric access. And secondly, if you compare with the cuff, this is a first generation cuff with it's like a single tube. It has no this, whereas when you see the blockbuster, it is bulkier at the tip and at the base. This sits at the base of the tongue. So when you inflate, it pushes off the epiglottis, it raises, so it doesn't need an epiglottis bar, okay? But it improves the oropharyngeal leak pressures because it has a posterior cuff along with this second generation cuff, and it improves the ventilation also, okay? So this doesn't have though a guiding handle for LMA, but it has a 4-way connector to stabilize. You can use this to stabilize the device after insertion, whereas the fast track has a handle here, okay? So this handle is held. You can, one good thing about fast track is you can be at the lateral position at the foot end, but you can just put it using this handle, and pressing this will increase the alignment of the ventilating port to the endotracheal, glottic opening for ease of insertion, okay? That is called a Chandy's maneuver. And cost factor, if you see, blockbuster is much lesser cost than your reusable fast track. This came around 24,000 some 10 years back for me, whereas blockbuster is just 7,500, okay? But then it is a single use and this is reusable. The disposable fast track is around 5,500. And hence, it is proved that the blockbuster LME is a better conduit for orotracheal intubation than the fast track LME. The first attempt success rate is much better. Lesser time is taken for intubation because of the angle and all. The ease of insertion is easier and ease of intubation is also easier. Lesser post-operative sore throat, and there is a channel for gastric drainage, that is a second generation it is, and lower cost and much effective ventilation because of its good oropharyngeal leak pressures. Coming to comparison of the blockbuster intubating LME to your ProSeal, okay? ProSeal, unless you have an fiber optic along with an iron tree, you cannot intubate through ProSeal directly as blind, because the gastric channel runs in the center, okay, just like your LMA Supreme. So the study, whatever has been done, is for conducting the anesthesia rather than intubating through it, okay? So the blockbuster is a better supraglottic airway device as compared to, if you see, both of them have your silicon pressures, both have your posterior cuff and the second generation cuff, but the ventilatory opening is much better for the blockbuster as compared to ProSeal, and it also has a gastric tube in center. So if you want to intubate, you will have to pass a fiber optic along with iron tree, leave the iron tree in place, and then guide the endotracheal tube and the fiber optic over an iron tree. But for mechanical ventilation, it is a high pressure, low volume cuff for Prosil. So it requires high airway pressures for mechanical ventilation, and when blind oral intubation, the Blockbuster serves a better. Okay. Now coming to Blockbuster, LME and iGel. Okay. The iGel is supposed to have the best fiber optic scoring and ease of insertion. It was promoted because of ease of insertion, and the fiber optic Brimacom score comes best with iGel because there is an elastomeric gel which expands with the every breath, and that improves the airway. The airway opens up. It's not like what it is seen. Once it's in place, it opens up slowly, and the direction goes towards the where your expired hot gases come. No? So it leans towards the airway. Okay. Now, but for the time required and the ease of insertion for both is comparable, but because of the good fiber optic scoring, even iGel can be a conduit for blind endotracheal intubation, but it takes more time because clearly the ventilatory opening is less as compared to the Blockbuster. Plus, it doesn't have a exchange tube guider, which is there in the Blockbuster. The hemodynamic profile is better with Blockbuster as compared to iGel, and post-operative complications like nausea, vomiting, sore throat, etc. were comparable in both the LMAs. Coming to LMA and your LMA protector. As I said, after the Aura Gain, most of the LMAs are coming with the for short airway tube, and it comes with the size of the endotracheal tube that can be passed through it. So most of them after Aura Gain are compatible for an endotracheal tube to pass through it. Okay, so this was compared with the blind orotracheal intubation through LMA protector and LMA Blockbuster, and you can see the LMA Blockbuster where it's a 30-degree angle when the ET tube, that is the Parker tip ET flexometallic tube that comes out, is at 30 degrees. Here it is 45 degrees. Okay, but still it gave a good effective intubating device, that is a LMA protector, and it has a good wide negotiating area for tracheal intubation, and since it is silicone throughout and a single piece, so it is good for ease of insertion is good. The gastric opening is comparable to your LMA Blockbuster. You can see, okay, it's a wider opening, and so the drainage tube was easily negotiable, and even the endotracheal tube, here you can see some hardening. So there is sort of an exchange device also in the LMA protector. There is not much difference in the performance of both devices when used for blind tracheal intubation, and hence both devices can be used for blind tracheal intubation in case of difficult airways situations with good success rate. But having a Parker tip endotracheal tube, definitely the Blockbuster wins here. Okay. Now, Blockbuster LMA initially had come only for adults, and later on they introduced it for pediatric cases also. It was used, this study where they used in a cleft palate patient for laparoscopic surgery, and even in neonates, size 1 was used where for ophthalmic surgery, and in pediatric patients with retrograthia for micro reconstruction surgery this is also a case report. And in all these cases, they were successfully the ventilation graphs, the EtCO2, and the patient comfort, and no trauma post-op. So the Blockbuster LMA was termed to be a boon for pediatric cases also. Thank you so much for your patient hearing. Any questions?
Excellent presentation, madam.
Yeah.
Mangal Dave sir is asking how much mouth opening required to introduce.
Around 2 centimeters mouth opening. See, it's more of, if the mouth opening is less for a freelancer, we can postpone the case. Actually, the surgeons themselves don't get it up to us, they only tell कि अरे mouth opening थोड़ा कम है, क्या करना है. For freelancer, I feel you should have a extremely rigid and this thing for an unanticipated, where we have to call for help. Everything has to be done. We are single-handedly doing. So for an unanticipated, it is the most important, we keep our equipments ready, which will help us in not allowing the patient to go towards apnea.
Yeah, this
or
LMA.
Hypoxia.
Yeah, I agree. This LMA and iGel actually are lifesavers. Many a times before before the introduction or invention of Tascope, I used to use this iGel and LMA, and they are really good. It helps in emergency conditions.
Yeah, just you can use it as a stopgap also, because just as I said, I routinely use when as you become more experienced, rather than trying repeatedly and leading to hypoxia, causing trauma inside, you you cannot pass. You can just put in the SGD and deepen the anesthesia, and then do peacefully, keeping everything ready, calling for help, and then intubating, trying for intubate. And if you cannot, you can always come back and put the LME and take the patient out. That is the safe thing when you are alone.
Yes.
There is one more question in the chat box. What is the function of introducer?
Introducer?
Yeah.
Or the pusher, you mean?
I think they must be meaning the pusher only.
Yeah, pusher is like your LME can just if there is not it can come out along with the when your ET tube can come out along with the SGD. So you keep the ET tube in position by pushing it and taking out the LMA at the same time.
Yes, thank you.
Because here the pusher I will show.
Hello.
See, the pusher fits in nicely. Even your where is this? Even Fast Track comes with its own pusher. See, it is made like this, Fast Track, and it sits on the ET tube. Okay, and this is the pusher for your Blockbuster. And the tip, if you can see the Fast Track tip and the Blockbuster, can you make out the difference? Okay. This is the pencil tip and this is the Parker tip. Okay, so this is it hits the posterior wall and then guides the tube into the glottis. Here it is not so, the distance is not much. Okay, you can make out the difference, the pencil tip and the Parker tip. Okay.
And there is one more question. Can't we use regular flex metallic tube?
You can use, but the same thing, this tip gives us more, that 96 to 99% success rate is because of that tip, I feel. Yeah. So
and
when
also
you are
these the tubes which come with the LMA, intubating LMA, they are longer compared to the normal tubes, normal flexometallic. Yeah, because you need to put it through it, then you need a pusher. So just to increase the
Yeah.
length, you need
It's
pusher, and these are
yeah,
longer
it's
ones.
longer ones. Yes, definitely longer ones. See the length of the tube is
Yeah.
yeah.
Yes, yes,
Okay.
yes, yes.
Yeah.
And what is the
That's why they
size
have
which is?
kept the airway tube of the SGD itself is short. So
Yeah.
after your this thing, you see the latest ones are all shorter airway tube to allow you to intubate through it. Okay.
And what size tube is available with 3 number 11?
I
3
had
number
shown
blockbuster.
the ET tube I had shown in that chart. So everything is I mean
No, that corresponds to our normal endotracheal tube of
yes. It is
6.5
corresponding to
or 6.
yes. It corresponds to the same number.
So through 3 number blockbuster, they
seven,
give 7 number.
7 number.
tube
4
or
is
6.5.
7.5. Yeah.
Okay. Okay. Thank you.
And what happens is, see, the opening, it's so wide. Okay. And the tube can wobble here and there, and you're putting a flexometallic. But then you have this, there is a guide inside, which allows it to go in one direction.
Okay.
Yeah.
Yes, there is a wedge basically. The wedge
Yes, there is
directs
a
it
wedge.
anteriorly towards the cords.
Yes.
Yeah, yes.
So that is a guide there, which is not available in the other tubes. Maybe protector has a little stiffening there, not exactly a guide, but it has. That is why the success rate is also as comparable to a blockbuster with an LMA protector. Okay, and the tube is separately available as a flexometallic tube ka jo rate hai. We get a Portex one for 1800, right? Similarly, the endotracheal tube for this one is around 1900. Okay. So this is a new pack which I had opened now. Any more questions?
I think we have covered most of the questions. Somebody is asking whether the Parker tip tube is it reusable?
In India, anything is reusable. So what I have done is like till I get another tube, na. So if I can easily put in a bougie, and if it's a long case, I may not reuse it. So I have changed the tube to routine tube. No, Torin also has a soft tip, blue tip, soft one, which that is also non-traumatic. So if it is more of an anterior larynx where I had difficulty in intubation, there I can use a tube exchanger and thread in this soft tip, okay, or a flexometallic tube if I have. But then a flexometallic tube, if I'm using for this and keeping this tube, the cost is same. And now in a day, it is easily available. Initially, it was not. So I used to change it to a routine tube, regular one, and keep this wash and ETO it and keep it with the kit, But nowadays, it is easily available.
Okay.
Yeah. Anything else?
Can we move to the next speaker?
Yeah.
Yes, ma'am.
Yeah. So our next speaker is also our moderator, Dr. Shantaram Pavaskar. He is a young freelancer in Thane since 2017, an alumnus of KEM Hospital. He has also worked as a cardiac anesthetist, and his special interest is regional anesthesia. Besides this, he is an avid traveler, and his travel blogs are very famous on Facebook, along with his wife, Dr. Who is also an anesthesiologist. They form a wonderful team. Now, over to you, Dr. Shantaram.
Yes, ma'am. Thank you very much for my introduction. So, straight. Yeah. So my topic is uses of borescope for awake difficult nasal intubation. So actually, this is not my innovation, but I got inspired by watching few videos of actually Dr. Mangal Dave sirs on YouTube. and then I made this for my personal use. So the components are tongue. This is a tongue depressor and few slots to introduce, the borescope, and 5 mm borescope I used. And this is a Talwalkar Buji, which I used for awake nasal intubation. So indications are
Hello? I think there is a freeze.
Hello.
Shantaram?
Yes, ma'am.
Hello? Yeah. Shantaram, there was a freeze of some 1 minute. So I don't think we could hear you. So can you just start from the equipment?
Yes. From which slide, ma'am?
From the first slide itself,
Actually,
actually.
Okay.
Yeah.
I will again share my PPT.
We heard the components, which is the tongue depressor, the borescope,
Okay,
and
ma'am.
the Talwalkar Buji. So after that, you can continue.
Now you are able to see the screen?
Yes, we can see the screen.
Okay, just wait. Talwalkar
Yeah.
Buji. Yeah.
You
So
can
the
go back.
role
You
of
can go
Talwalkar.
back. You can go back one more slide.
This one?
Or before that? Yeah, this from here you can start.
Okay, so indications are mouth opening one finger or less for awake nasal intubation, or if any suspected difficult intubation. Preparation, counseling of the patient is very important. Lignocaine jelly in nose, then lignocaine spray 10% in oral cavity, 2% lignocaine intratracheal, lignocaine adrenaline nebulization if possible, and you can give sedation, glycomidas, Fortwin or fentanyl to make the patient comfortable. Lignocaine jelly on Buji is important for the smooth ET tube insertion. So why I use Talwalkar Buji? Because it gives sturdiness to the tube and it helps in shifting the tube anteriorly in nasopharynx towards the vocal cord. Because if the mouth opening of the patient is less than one finger, it is very difficult to insert Magill's forceps and to maneuver the tube anteriorly. So this is just a video of can you see or is it lagging?
No, we can see.
No.
But we can't hear anything. Is there a sound to the video? Because we cannot hear anything.
Hello.
Yeah. We could
Am I
see the
audible?
video. Yeah, we could see the video, Shantaram, but we could not hear anything. If there was an audio attached to it, that was not audible. I think you can run the video and speak it out.
Ma'am, am I audible?
Yes, now you are audible. But the video is not audible. Shantaram, can you hear me?
Can you see the video?
Yes, Shantaram, we can see the video, but we cannot hear the audio attached to the video, but we can hear you. So you can run the video and talk. That is also okay.
Hello. हेलो
Yes, Shantaram. We
सर
can see.
दिख रहा है कि नहीं दिख रहा है?
दिख रहा है, but there's no audio to it.
नहीं,
but it is
ऑडियो
quite-
नहीं है सर,
अच्छा
ऑडियो
अच्छा,
नहीं है।
then it is self-explanatory. Don't worry. You can talk if you want something about the video, what you're doing.
Yeah, you can see the tube is going in. Ask the patient to take just deep breathing. This is a second case. Also, the mouth opening is one finger. You can see the vocal cords. This is a case third. The mouth opening is one finger. So this Talwalkar Buji, it has a one button there, and by pressing it, you can see the tube is going anteriorly. The tube is on posterior side, and just by pressing the button, it will go anteriorly, and then you can push it inside easily. This patient has a mouth opening less than one finger. And I was trying to put the tube through both the nostril. I was not able to pass the tube. Then I tried it with Buji also. Buji was also not able to go inside. Then I put the nasopharyngeal airway and then I was able to pass the Buji. And I could see the Buji inside the mouth with the tongue depressor attached borescope. Then I removed the nasopharyngeal airway and then I inserted tube in it. By applying some jelly. Then I remove Buji and inserted the Talwalkar Buji. So you can also see you can also see that the larynx is very anterior. So in this mouth opening of less than one finger, you cannot insert any Magil. So just by pushing the button over the Talwalkar Buji, it will just shift the tube anteriorly and then you could negotiate inside the, see, you can see the trachea is, the video is not that good, but yeah, see, the larynx is very anterior. This is the larynx. You can see the cords, it is very anterior. Yeah, now the tube is in. Yes, that's it. So the advantages are it is cost effective, easy to sterilize, easy to make. Patient tolerance is good with the tongue depressor. There is a less gag reflex, and less space is required to put scope inside the mouth. And you can slightly give angle to change the shape of tongue depressor if needed. A disadvantage is that there is no suction port, and you cannot insert a Talwalkar buji in less than 6 mm cuff tube or North Pole tube, and it is less sturdy than other video laryngoscope. Thank you.
Fantastic, Shantaram. I remember once when we were in one hospital, Shantaram was in the next OT and I was in the other OT. And that was the time I had seen him intubating it with
Hello.
this. Am I audible?
Ma'am, I can't hear you actually.
Okay.
I don't know what is the problem.
Audible now?
Yes, Manisha, you are audible.
No, okay. So I remember that a few years
Yes,
back
yes,
when we
ma'am,
were
I can hear
working
you
in
now.
one hospital,
Sorry, sorry.
Shantaram was in the next OT and I was doing some other case. And that time I had seen his innovation and I was very impressed by that. And so when the opportunity came for this webinar, my first thought was of
Yeah,
Shantaram only should be the moderator for this webinar. So thank you, Shantaram. That is a very nice innovation and very nicely presented also.
Thank you, ma'am. Thank you. Kala
Any
ma'am,
questions? Please take them.
from where can we buy borescope? Ma'am, it is available on Amazon. Yeah. You
And
can just, yeah, Mangal sir is saying something.
one more to that limitation you said, no, it cannot be used. The Talwalkar Steelite cannot be used with North Pole tube because
Yes, sir.
it is very longer. So what we can do is there is a bulb inflation technique. If the tube is going posterior, we can
Okay.
inflate the bulb of the tube so the tip
Okay.
will come up.
Yes, sir, definitely.
Once it is entered into larynx, we can deflate the cuff and push
Deflate
the
the cuff. Okay.
further. Yeah.
Yes, sir.
Any more questions? It's an open forum. Anybody can ask questions and join in. No more questions. So I was just calculating just now. So that whatever we have heard today, if you put the cost of everything, it is less than 20,000. Like I said, it is less than the cost of a mobile phone that we are using. But these devices will be life-saving, not only for the patient, but also for us and our practice. So I think it will be a very good idea if everybody could have at least some of these in their armamentarium to start with, especially those who do not have access to bronchoscopes and other high-end devices.
Yes.
Yes, agree, madam.
Any more questions? Parna, anything more? Dr. Katkade, anybody has any comments to make?
And I'm speechless after seeing the all presentations and everything. So beautiful. Excellent.
Thank
Very
you, sir.
innovative. Actually, when I met Shantaram earlier, rather, he showed me his own device.
Yes, sir. Yes.
I was really impressed.
Thank
I
you,
was
sir.
really impressed, and really, and and everybody. I mean, Dr. Kala's presentation was superb. I wish, and Kala has studied all the laryngeal, supraglottic airways so in depth, and she has an academic background also. I mean, she came with the references, so it's very interesting.
Somebody has just asked.
Sir, then we should start, sir, such fantastic this thing, and I mean they should publish, sir. So because it will go a long way.
We must.
All these innovations, or else, I mean, okay, we have this, but publication will leave the footprint for give a legacy to our.
Yes.
Yeah.
And
So I think
Shantaram,
हाँ sir.
only thing is, since you asked my comments, I
Yes, sir.
suggest that whenever you are doing such difficult intubations, it's good practice to put nasal oxygen or some nasopharyngeal oxygenation
Yes,
device, because that always gives a margin of safety and you have some extra time. Patient will not get hypoxic. Fortunately, you are done. Most of the intubations are done awake.
Yes, sir. Yes.
Yeah. So it's a very good thing. And I think in crisis, sometimes even this awake intubation with a video laryngoscope and a gum elastic bougie it's a great asset. And regarding the bougie, I think, see, actually stylet, it comes as a hockey stick stylet, that is a Parker stylet which used to come. The hockey stick stylet is better sometimes, If you see lots of people in Western world, I saw they all are using straight blade laryngoscope and they have hockey stick stylet. They make a stylet hockey stick. So what they find is the straight blade. Recently, I've been to a hospital. They are routinely using straight blade for intubation and hockey stick stylet. So, and whatever, I think you should use the first choice of devices, whatever you are comfortable and you are expert in that. Like Dr. Shantaram is very comfortable with his device. So one has to practice Dr. Shantaram's device in a normal patient and then practice for difficult airways.
Yes, sir.
That's
Every video laryngoscope has its own learning
yeah,
curve.
the learning curve, yes.
Sir, actually, all video laryngoscope we require some form of bougie or a stylet to intubate.
Yes,
So
yes.
what we have seen is that for all laryngoscope intubation, the hockey J-shaped tube. If you
Yeah.
take with the tube, that is the easiest part to do. So prior to that, we can do a preformed with the stylet, and it becomes very easy to intubate having a J-shaped tube making. So that becomes a very advantage.
Yeah, I agree with you.
Yeah.
I agree. I can show you some. That's a very good point, Dr. Bhavesh, you have said. Dr. Bhavesh has a very good point to say. And see, this is the. Okay, can you see this? See, what you mean is this tape, no? Actually, somebody from India should devise this type of stylet, That is, we have got lots of innovative brains. Dr. Kalla, what you said. Dr. Bhavesh.
Sir, we have this routine stylet, metal stylet, what we have.
Yeah,
we put in that and just put and make it as a preformed in tube like that.
Yeah.
So we have this. We have this type of stylets available in India, sir.
Sir, this is available. Best Data has a video stylet.
Yeah, video stylet also, correct.
Video stylet also in similar way, where you can guide in the tube and the distal part is attached to the camera.
Okay,
that's good.
Yeah.
How much it costs?
So, but then these are very rigid.
How much it costs?
Bonfil, sir, it is 25,000 only.
Intubating stylet?
Yes. Best Data is giving for that much. It comes along with its 6 metal autoclavable video laryngoscope. It comes along with that. So they are giving this extra piece for 25,000.
Ma'am, for oral intubation.
Is compatible with the video laryngoscope. Ahmedabad based person, sir, that is.
Very interesting.
Yeah.
Earlier there were BPL also people had all these.
But then you cannot do it like your Bonfils, Bonfil, you can do it, use it for intubating directly, but this is quite rigid, so it's traumatic. So you have to use it along with the video laryngoscope. Yeah. I have taken demo of this, so.
Sir, this stylet is available with GlideScope.
Yeah.
Yeah.
Yes.
It comes with it.
Yeah. This is a GlideScope only. I just picked up from GlideScope only.
Yes.
But it's very expensive. GlideScope is very expensive, not that much,
Actually, 7-8 years back, I purchased a boroscope from Amazon, and I attached with the sticking plaster to the basically metal stylet. so that even less than 1/2 centimeter, you can actually see inside go and then just see whether just for the purpose to know that whether we can do intubation with that type of, we can put with that like what Dr. Shantaram does with the tongue depressor and then do a
Yes,
nasal
sir.
intubation through it.
Mm.
So I used to do lot just to check it. That's all. Never intubated with it, but just to check it. And with the tongue depressor, I used to attach that thing, and I tried oral intubation, which was not possible for me to directly do. And Dr. Mangal Dave, I think he did a fantastic job by doing this one similar thing, but with a very innovative and scientific method.
Thank you, Dr. Bhavesh.
Yeah, so I purchased also for Dr. Mangal's Tarscope.
Yes, sir.
Yeah.
Any more questions? We can now proceed for the vote of thanks.
Actually, can I see there is a device called Tesla two-way articulating boroscope with light. It costs about 12,000 rupees on Amazon in USA. So if somebody has access to that, you can very well procure it for it is about 12,000 rupees. I don't know. We have not tried. I have not seen if somebody can really.
Is it a flexible type, sir?
No, it is a flexible. It is a
Yeah.
rigid, but it has a
I
boroscope.
saw it on Amazon. Yeah.
Yeah, Amazon calls.
It
Yeah.
has its own screen and everything.
Yes, and it is only $129. $129 बोले तो 8.5 plus 12 it's but our devices are great. Congratulations. Thank you very much. Good.
Actually, one of the biggest advantage of all these video laryngoscopes or borescope is that the OT staff can assist us in a much better way. They actually
Yes.
know what we want to see. Otherwise, it is aisa pressure to, waisa pressure to, idhar hila, udhar hila. All that just gets negated, and they are quite excited when they see what is happening. So that has been a very good advantage for me personally. Now they know exactly what is to be shown to madam and where she wants to put the tube. So that way it has become even more simpler. Not only the equipment has improved, even the assistants have improved in the work that they do.
With the whistle, the patient also participates. Patient also celebrates intubation.
Absolutely.
It's only
Yeah,
not the
I
anesthetists,
asked
the
the
OT staff. The patient also joins the party here.
Yeah,
Even
even attention is diverted. कि मुझे बजा नहीं है, विशल बजा तो मैं नहीं बजूंगा, something like that.
Even in Dr. Dambali's videos, we could see the excitement on the faces of all the people who were surrounding him while he was doing the intubation.
Yes, madam. Yes, madam.
Very nice. Okay. Parna?
Nilima, please
Okay.
go ahead. Yeah.
Nilima, can you please give the vote of thanks?
Okay. So we are coming to end of this very engaging webinar. And me, Manisha, Aparna, we are very happy to put this together, very excited and happy. So thank you, Thane ISA office bearers. I wish I could do that.
I can't.
I know. So thank you, Thane ISA office bearer, for bringing such beautiful webinar. Thank you, Dr. Manisha, Dr. Parna, Dr. Katkade sir. Thank you, SAM's office bearers, for the support. Thank you all the esteemed speakers, Dr. Mangal Dave sir, Dr. Vivek Gupta sir, Dr. Hemant Dambale sir, Dr. Kalai Swaran, Dr. Shantaram Pavaskar for the presentations. Very practical points were discussed, and I'm very sure that all these gadgets will give us some more confidence in managing difficult intubation cases. Thank you all the delegates. It was overwhelming response, and it gives us really good moral boost to conduct such CMAs in future also. And thank you very much, Mr. Ganesh from Geneca. We keep troubling him so much all the time, but very patiently he helps us every time. So thank you so much. And with this, I think Yeah, let us say good night. Okay.
Thank you, our MMC observer and all the delegates who join in large numbers and encourage us.
Yes.
And watch out, we are coming with another exciting webinar on 7th of August. So stay tuned.
Yes, surprise.
Yeah.
Thank you all
Thank
of
you,
you
everybody.
once again. Thank you so much.
Thank you.
Thank you so much,
Congrats.
Dr. Gupta, Dr. Dave, Dr. Dambale, Dr. Kala, and Shantaram. Thank you,
Thank you,
Katkade
ma'am.
sir,
Thank you
and-
very much.
Thank you so much.
And
I'm
congratulations to
very-
all
Manisha?
speakers. You all are great, dear. Great.
Thank you,
Not
Kala.
getting into the got worked.
So we had one little danger moment, heartbeat moment, because Kala could not join in. The platform had already got full with 100 people. So we had to remove somebody. So sorry to whoever that person we had to remove so that Kala could join in. But I hope he joined on
I'm so
YouTube.
sorry. Yeah. Thank you
No,
so
no.
much. Yeah.
Thank you
Okay,
and
chalo,
good
bye.
night,
Thank you.
everybody.
Thank you all.
Bye.
Good
Thank
night.
you.
Thank
Bye.
you.
Thank you.
Bye.
Thank you, Parna.
Bye. Thank you.
Bye
Thank you.
bye.
Bye.
See you. Okay, we are having a picnic on 20th July this Sunday. And if anybody is interested, please join in. Kala, you are also welcome. Dr. Dambale, you can travel from Nasik. It is at Shahpur.
Yeah,
Anita.
2 hours drive for him.
2 hours drive
Anita.
for him and us.
Yeah.
Anita also can
Anita
join.
madam.
घेऊन या sir.
Vishal घेऊन या.
Anita madam, thank you, Dr. Anita madam. Thank you very much. Thank you. Bye.
Thank
Okay,
you.
good night.
Good night. Bye.